Okay, we'll start with the first case. Are you there, Usama? You want to take over the screen and do it? I'm going to stop you from time to time at the screen to intervene and ask questions. Okay, we're going to run this like it's a tumor board, like you have a patient, and we're all trying to sort out what to do, what the next steps are. Well, you gave us the answer.
Hi, RJ again.
You gave the answer. You're not supposed to give the answer.
Are you getting my voice? Because I think the internet connection. Okay.
Yes.
Today I'm talking about a biatrial cardiac myxoma. Of course, myxoma is the most common cardiac tumor. But biatrial myxoma, I have seen it once 20 years ago. And this is the second case I have seen about 2 years ago. So myxoma is the most common primary cardiac tumor with an estimated incidence of 0.001 among the general population. The left atrium is the most common site of origin of cardiac myxoma, followed by the right atrium. Myxoma represent 5% of all cardiac myxoma, estimated about 2.5. Actually, to the available literature, only a few cases of biatrial myxoma have been reported so far. And they are generally described as a single tumor reaching both atria. We present a rare case of two independently growing atrial myxoma who underwent surgery on thoracic and vascular surgery center at Egypt. A 54-year-old female presented to our department with NEHA class 3 for the past 6 months. She denied any past history of cardiac illness. Her pulse rate was about 120. Cardiac auscultation revealed a mid-diastolic rumble across the mitral valve, followed by a tumor blob. Patient's electrocardiogram showed normal sinus rhythm, right axial deviation, and some T inversion in L3 V1 to V4. Patient was further analyzed initially by transthoracic echo, followed immediately by transesophageal echo. It revealed large left atrial mass attached to the interatrial septum. It was 6.6 by 6.5 or 5.5 centimeter, encroaching on the mitral valve. Of significance, another mass was also evident in the right atrium, almost same size, 6 by 5. Notably, the right atrial mass also was attached to the interatrial septum.
I'm going to stop you there. Can you go back to your last slide?
Yeah.
I'm going to ask Dr. Rogala. No, back slide.
Yeah.
First, I'll ask Dr. Lestucci. We'll ask her from an echo point of view. Have you seen anything like this? And Patrick, I'm going to ask you the same question.
No, I never seen something like this. Biatrial, no.
Patrick?
Well, I have seen one case, and that was in a publication from, I believe it was 2012, out of China, but I have never seen a case here in my practice.
And we don't have motion on this, but
unfortunately, no. It's 2 years ago, and I just collected the available data.
I'm not saying in a bad way. I'm saying we don't have motion like this. I'm glad you have that picture, because the picture is worth 1,000 words. I mean, that's a gigantic tumor. I had the opportunity to go teach in Ethiopia, and I saw the biggest myxomas or cardiac tumors that I've ever seen in my whole life, and they were something like this.
Actually, patient was symptomatic 6 months ago, so yeah, it's maybe neglected.
When you see myxomas like this in Egypt, Usama, are they usually big like this? Not biatrial, but are usually big tumors or smaller tumors?
Well, we see smaller tumors, 1.5 centimeters and 6 or 7 centimeters as well. but all in the left atrium or right atrium. Yeah.
May I ask, where was the point of attachment? Was a sessile or was a small point of attachment in the lower part of the interatrial septum?
Well, the right one was pedicled going to the fossa ovalis, and the left atrial mass had more attachment to the septum, broader septum, about 2 centimeters.
The difference between a malignant and a benign tumor of the atrial septum, it can be very deceiving.
That's right.
How certain were you that this was a myxoma?
What is that, sorry?
I said that the difference between a benign and a malignant tumor can be very misleading. Can be very deceiving in terms of a difference between a benign and a malignant tumor.
For sure. You mean intraoperatively or echocardiographically?
Was it obvious on the electrocardiogram that this was a myxoma?
Yeah, the echocardiographer suggested myxoma. Yeah.
Yeah, they often do when they see something on the tumor. But did you see the echo? Are you used to seeing the echoes there? Did you see the echo?
Yeah, for sure.
And did it look like a myxoma to you? Did it move like a myxoma?
Yes, it was, and going through the mitral valves like the classic myxoma. Yeah.
If I may comment, it is the only thing that is against the malignancy is that the interatrial septum seems free from the tumor, so there are 2 distinct tumors. But on the other hand, when an echocardiographer say it's a myxoma, it's just because they think that is the more likely diagnosis is myxoma, because they usually you see myxoma, but you cannot distinguish by the echo a myxoma or a myxoma or a sarcoma, myxoid sarcoma. It's impossible. This is why some myxomas, some sarcomas are misdiagnosed as myxomas.
The left side is pedunculated through the through the mitral valve. Was the right side just as mobile as the left side? Or is it less mobile?
Yeah. Both of them were reaching to the valve, but the left one was more going to obstruct the mitral valve.
Juan, do you have any comments from South America?
No, RJ, I haven't seen one of these before. We do see occasionally very large myxomas, mostly on the left side, and ones that can prolapse into the left ventricle, obstructing the LV inflow, of course. And as Dr. Lestucci said, there's really no way of knowing whether you're dealing with a sarcoma or a myxoma until you go in and remove them. So I'll be very interested to hear what the approach to this massive tumor was.
Yes, Dr. Wogala said that one of the things they could do is an MRI with gadolinium enhancement. And how would that differ with myxoma versus sarcoma or other malignancy, a secondary tumor or something?
You mean from the diagnostic late gadolinium point of view?
Yes. So
the late gadolinium sort of shows you a chronic fibrotic tissue in a mass. So there is a caveat here. Acute and medium acute myxomas do not show late gadolinium enhancement, but there are some large ones, in particular when they become chronic, where you might see some at the base and the pedicle, you might see some enhancement. Sarcomas have a very heterogeneous enhancement anyways. We wouldn't use late gadolinium, we would use the early gadolinium perfusion. In sarcomas, very heterogeneous, and no uptake on myxomas. So for the differentiation, we would use the early phase, the perfusion. Late gadolinium helps us to distinguish a fibrous component in tumors from no fibrous component.
So for instance, if there's a late gadolinium enhancement, it's probably not a sarcoma because they grow too fast.
Correct. And it's very aggressive tumor. It doesn't even have time to build anything, right?
But they would have early gadolinium enhancement because
Yes.
there's good flow through them.
Yes, that is correct.
Now, what about a PET scan? Dr. Lestucci talks about a PET scan. I have read literature about myxomas sometimes do light up on a PET scan. What are the problems with a PET scan with a myxoma? And
well, there's a number of challenges. As you said, well, a negative uptake doesn't exclude anything. That's number one. Number two is they're mobile, they're moving. And so spatial resolution can be an issue in the heart. Then the myocardium is showing an uptake. So it's okay. I think PET is great when it comes to establishing the activity of a sarcoma and anything else, in particular when it goes outside of the heart. For differentiating myxoma, I'm not sure this is the primary target.
I think we with the PET, to reduce a myocardial uptake at PET, you should give a ketogenic diet the day before, and the longer fasting period, at least 15 hours of fasting hours, and you abate the uptake. I know that PET is not, may have gray zone, but in such a large mass, the PET the uptake is visible. Also, if it's mobile, it's a problem if it's a small mass, and we distinguished if the uptake is very high, it's probably a malignant tumor. Maybe also a lymphoma, also lymphomas. But if you have no uptake or very low uptake, it's probably malignant. So it's, I think that no one technique is enough to make the diagnosis. But the pathologist makes the diagnosis.
That's
if you put several techniques together, you can balance the limits of one technique to the possibility of the other technique.
Would agree. Thank you. Absolutely correct.
Dr. Lestucci, you're an expert in echocardiography. You were born an echocardiographer, I understand. So you know, people ask me, especially the students that I teach, I get somebody who I think is a myxoma. It's something in the left atrium coming from the atrial septum, highly mobile as this is. And they said, aren't you gonna get all the other imaging you always talk about? When do you stop getting imaging on something that looks like a typical myxoma?
But I don't think that you can stop imaging. So I think that the best thing, as Cesar said, si vis pacem para bellum. So if you want the peace, prepare to the war. So if you have not, if you have any doubt about the benignity or malignancy of this mass, approach it as if you are malignant. So prepare to make a wide reception and so on. In this particular case, this is a still frame, so I don't know if moving maybe is easier to see. But I've seen also cardiac lymphomas that are much like this one.
Yeah, I was going to ask you that question.
I had a case of cardiac myxofibrosarcoma who was operated as a myxoma, was completely indistinguishable from a myxoma, and actually was malignant. We had also a case of a patient who had at the third operation, second redo operation of a myxoma, was turned out to have a myxoma, a mass, including a part of myxoma and a part of malignant tumor. So this is really challenging. A mass so large, so the patient was symptomatic, the mass were large, so there was no other option than going to surgery. But going to surgery prepared to find something malignant. I say, okay, if it's malignant, I have to be ready to cut larger and so on.
Yeah.
I think the echocardiography is not enough. Can give you some impression, but not the diagnosis.
I've seen a few I've seen a few lymphomas and a few sarcomas, obviously, and I find that if it's very solidly immobile, that is an indication that it's not probably a myxoma. If it's mobile, highly mobile, it's either a myxoma or a fibroelastoma. This could be a fibroelastoma. Obviously, we haven't seen it move. But we've had a number of patients who've had fibroelastoma who have gadolinium uptake and they move around. It looks like a myxoma. It even has the little lakes inside there. It looks like they have lakes inside there and they're fibroelastoma. But I found that if it's not mobile, that's why I really be careful about what I do next in terms of operating. Are the lymphomas, you say, sometimes highly mobile like a myxoma?
Yes, I have seen a sarcoma highly mobile like a myxoma. So I agree. If it's not mobile, it's more likely to be a sarcoma or a lymphoma. If it's highly mobile, maybe it's a myxoma, but maybe it's a myxofibrosarcoma. You cannot say before.
So some of those malignant tumors can be highly mobile.
But since the myxomas are much more frequent, you can, if you say, okay, it's a myxoma, you have more probabilities by an analysis. You have more probability to be
but what
right, but just because myxomas are much more frequent.
Right. But what I mean is, that can you have a highly mobile lymphoma?
Yes, I've seen also this.
Yeah, you have, eh?
Yes.
I'm going to ask Juan a question. Juan is probably a way better surgeon than I am. Do you do a minimally invasive surgery? You do. I know you do.
I do. Yes.
Do you do this minimally invasively?
Oof. Probably not, RJ. I wouldn't be quite comfortable approaching this through a left mini thoracotomy, which would be the ideal approach to the left atrium. Particularly considering that you might have to do what Mike Reardon would call a partial auto transplant. This would probably require mobilizing the heart and detaching the aorta, detaching the SVC in order to be able to do a biatrial approach and remove the entire tumor as well as attachments to the septum. From this image, what I want to ask Usama is whether there was involvement of the roof of the atria. Was the tumor attached to the roof of the atria or not at all?
No, not at all. It was totally to the septum.
Okay. So
yeah, unfortunately, yeah.
In short, RJ, I would not be comfortable approaching this through a minimally invasive incision.
If it was one side, just one side, would you?
Yeah, if it's highly mobile and you can clearly see the attachment, I wouldn't see why not. My concern would be the handling of the tumor, being able to avoid seeding or disrupting the tumor, given how friable myxomas are in general. So if I have the adequate tools and a bag in order to remove it from the chest, I would.
And what about you, Juan? When do you go on to the next step other than just saying, yep, this looks like a myxoma? I mean, highly mobile, we all think about that. But Dr. Listucci said sometimes malignancies are highly mobile as well. When do you sort of stop and say, oh, maybe we better move on to a CT scan or an MR or something like that? Or a PET?
Our approach, RJ, is the same Patrick was suggesting. We usually go straight to an MRI with late gadolinium enhancement to try and characterize the tumors. That of course is if you have a patient that can tolerate being supine for a prolonged period of time while the MRI is being performed. From what Usama or Dr. Hamza is describing, this is a patient that had to be taken to the OR fairly quickly, and a diagnosis made intraoperatively and based on pathology.
Yeah, because the patient was so symptomatic. But do you do an MR on all your quote unquote myxomas, or just some of them? I must say I don't. Yeah.
No, I just some of them. If we suspect a malignancy, and we're not quite sure, you can never be 100% sure. But if the tumor is fixed, if we're concerned that maybe a malignant, there may be a malignant component to it, or if we have an unusual location of the tumor, we then proceed to an MRI preoperatively.
Okay, great. Patrick's made some comments there. I'm glad that he made those comments. If you want to say anything other than the comment.
Yeah, I just say, sometimes MRI is not readily available. And I mean, we're looking at an international conference. Not always would someone have MRI with this technology at hand. I mean, many of those tumors are incidentally found, and we use CT for all sorts of things. Meanwhile, for screening, for cancer, if patients have something else. So when someone comes across a low attenuating, pretty round, well-defined mass in the typical location, it is possible to suggest myxoma on CT as well. I would be careful in not saying that's definitive, but the appearance strongly might suggest myxoma. And then is the question, if you don't have MRI together with echo, would that be sufficient enough to characterize the mass? Possibly, yes.
And what about if it's a lymphoma or a sarcoma? What's the difference between?
Yeah, that's a very good question, RJ. The challenge often is it depends how the CT was being done.
Yes.
Most of the time, we use CT for many other purposes in malignancies. And then there's enough time for the contrast medium. We typically call it portal venous perfusion phase, which means 50, 60 seconds after injection of contrast material, which is enough for lymphomas and sarcomas to take up in the early phase contrast. So they are typically bright. And in those circumstances, we don't overwhelm the heart with dense contrast material. So we have some differentiation here. The challenge comes when we use first pass imaging, for instance, in cardiac CT, where really the goal is to see the coronary arteries. This is first pass, and almost all tumors are dark. So then I would be very careful in making any further interpretation. The option is always to take a late phase imaging once you identify on the spot, but typically that's not being done.
I mean, that's important. That comes down to the history that you as a radiologist get. Most often you guys get a history, please do CT scan, and that's it.
Yes.
But if we say we're worried about a tumor in the heart, you would protocol it differently.
Yes, that is correct. And CT is being done for staging, right? So the advantage is you can get some initial assessment plus the staging at the same time. I would, however, say if you have a dedicated question, as we discussed before, specifically myxoma versus everything else, I would go, if I have the choice, to MRI.
Yes, as you said, if you're lucky enough to have one in your institution. I think I'm just going to make a general comment before we let Usama carry on. It's very important if you're going to get into the cardiac tumor game to know your radiologist very, very well. And it's really, really important that you sit with your cardiologist to go over echoes and with your radiologist to plan what kind of imaging to do next. It's so important. So I just wanted to make this clear. Okay, Usama, I'll let you carry on. Sorry to stop you there. It's not that we
it's okay.
That's what you said. It's just a good talk. Okay, you can move on. I think it's somebody has their phone and their computer on at the same time. Carry on, Usama, with your next slide. There we go.
Okay, sure. Well, we took the patient to the OR immediately because of her general condition. Actually, she was deteriorating once we had done the transthoracic and they gave us this unusual picture. We carried on the trunk to the OR immediately. Our approach for this surgery is right atriotomy. We found the right atrial mass attached to the fossa ovalis. I removed the right atrial mass, shaving from the septum. Then I started to identify the attachment of the left atrial mass. Started to open the septum, excise it circumferentially. I had to excise it generously because the attachment was broad than the right side. Actually, to deliver this large mass from the left atrium, I usually and safely go for left atriotomy to help delivering the mass instead of squeezing it, avoiding fragmentation or disattachment of anything from it. So actually, it's right atriotomy helped by left atriotomy with complete excision of the septum that repaired with autologous pericardial patch.
Actually, your behavior was optimal. So if even if this was not a myxoma, even if it was a sarcoma, you made a wide exclusion of the interatrial septum. So the risk of leaving some inside tumor was avoided. The problem with the surgery of supposed cardiac myxoma is if you could cut the insertion and not around the insertion site. So this is at this point with these masses, it wasn't unnecessary to say before if it was a malignant or not. And what was to do was what you did actually. So cut wide, cut wide and not leave anything inside because
that's right.
Okay.
This is a myxoma that has a fibrotic exterior to it. There's your thing there. When you first cut in, did it look like a myxoma to you? Did you know what it was?
Yeah, actually, as you can see, especially the left picture, yes, it looked like myxoma to me.
It looked like a myxoma.
Yeah.
That picture looks completely different than the one on the previous page, previous slide. Can you go? This was the right side. No, this is the left-sided mass. That one there, was that the right side?
That's right. This picture for the right only, for the right mass only.
And the one in the bucket, what was that? Was that the same?
It's the other one.
That's the other one. Can you leave it there, Patrick?
Yeah.
First of all, do you think that moved very well on the echo, eh? That moved very well in the echo. Was highly mobile. Always frozen. Patrick, can you tell us? We're looking at that. It looks like it's a fibrotic exterior and a tumor in the inside. What would you expect to find in MRI with that? Would you expect to find late gadolinium outside, and how would you expect?
Exactly. I was thinking the same thing if I should comment on it. So those are the components in myxomas which can actually take up some contrast on late phase. In fact, when you see it, there looks almost like a polypoid mushroom type of internal structure. And the fibrotic tissue is typically then attached at the bottom, almost like the pedicle in a polyp. So had we done an MRI, which was not available here in this case, I would suspect it would light up on LGE.
And do you think you would have made the proper diagnosis here?
You know, the fact that early perfusion, early gadolinium enhancement is practically non-existing, I would assume, again, with all the uncertainties we're having, it would be a pretty firm diagnosis, giving those features.
Juan, do you have any comments about what it looks like?
Oh, not really, RJ. I agree with all that's been said. It's not as typical myxoma as you would expect, though. Right? Not the multilobulated, friable, almost gelatinous mass
Yeah.
that we're used to seeing. And on the next slide, you get the impression that it has that kind of fleshy.
Yeah. Move to the next
Fishy.
slide, please, Usama. Yeah.
That fleshy. I mean, it.
Can you show us the next slide? There you go.
Yeah, you see that. I mean, it's hard without touching it, but it looks meatier than I would expect a typical myxoma to look and feel.
You know, the when I said it, you know, we haven't seen the images, so there is a degree of speculation. But if you have a neoplasm, a tumor in the heart that has a significant portion without any reaction to the surrounding contrast material, that's very indicative. And the challenge always comes when we have two different entities at the same time, right? So it's not totally excluded that you have two histologies at the same time. Would be super rare, but we are not looking at a typical case anyways. So I would assume we would have described it as most probable myxoma, and that would be very likely the diagnosis here.
In the time where you're questioning the diagnosis, I will send the person to our cardiologist to do a transvenous biopsy of this. And you can see in the previous page, there's a layer of fibrosis overlying the tumor. And this is one of those times where the transvenous biopsy, this was, you know, if we haven't seen the moving images, but, and the patient needed to go to the OR, but I'm talking about a different situation where a person has a tumor, you're questioning what it is, it may not be moving very much, you ask for a transvenous biopsy and it comes back as non-diagnostic. If you were to have not both sides, or even we'll talk about both sides, one side, what can you do for us, Patrick, from a percutaneous point of view? Can you go through the back like an old Sohn's technique and go through the heart, or what would you do for that if we were to ask?
You could, yeah, that's a very good question, RG. You could. I have to tell you, the atria are probably the most challenging areas for biopsy for access reasons. One could come from interior, but then we need to be careful that we, you know, space out the coronary arteries on either side well enough so we have access. We could, and we do it, let the lung collapse entirely, like in pneumothorax, we use carbon dioxide and then get access to the atria. It's possible. I would argue, though, atrial biopsies are probably the riskiest one, much more than further anterior, but depends on the location and the size of the tumor. I think it would have loved to explore it. One needs to see the images.
Yeah, so could you theoretically, I'm not going to push you on this because you're in my hospital, could you get an intracardiac mass biopsied?
Possible. Yeah,
is
possible.
That right?
Easier through the left ventricle than through the right, because there's more vascular mass that helps seal any access route. That is possible. We know if we go through the ventricle mass that it doesn't really cause any harm. You know when pacemakers drill through, it doesn't cause any action. But again, we're entering really very dedicated biopsies that need a very thorough investigation and clinical question.
Yeah. Juan, do you have an interventional radiologist that will do percutaneous biopsies for you, or am I more lucky than that?
No, you're a lot luckier than I am, RJ. We're looking to send somebody to get trained over there. But our interventional cardiologist will do some. The problem is you need a particular kind of catheter and needle in order to get enough tissue. some that we don't have access to in Colombia right now. So most of our needle biopsies or transvenous biopsies will come back indeterminate. So we tend to, you know, in large tumors that are you know facing outside of the heart or that protrude outside of the heart, either ventricle or atrium, we tend to do those under direct vision, and we will approach those thoracoscopically on occasion. But as we know, most of those are highly vascularized. You mentioned the talk on given last year on that topic. It's a fascinating topic, and you know what we tend to see is a lot of these patients coming to us with complications, having had complications from percutaneous attempts to biopsy those masses. So that's why we've evolved to a thoracoscopic approach to those patients.
That's interesting. Yeah, we haven't had as many problems, but I still think it's worthwhile. I've had some good luck with lymphomas. 1 week I had 3 lymphomas, and two of them were biopsied. 3 of them were biopsied percutaneously. We got the answer, but some of the times, as you say, it comes back indeterminate. But I think it's worthwhile to try, as long as it's not too dangerous. It sounds like you're having some issues that you've gone to a different approach, but you're lucky also to have a thoracoscopic approach, because we don't have that luxury. As I said, you're more advanced than we are here.
No, come on.
All right, Usama, do you have any more slides that show us an interesting case that generate a lot of good discussion?
Well, just running of the pathology, it showed classical atrial myxoma. We don't have any more comments. It was classic myxoma.
Yeah, you can definitely see the myxoid tissue there, can't you?
Yeah. So patient went well and followed up for 2 years. We follow about 6 months. Do you have a protocol for follow-up of these cases, RJ, by the way?
So I tell people that they should have an echo for the first 5 years, because I'd assume that the recurrence rate is highest in the first 5 years. But for all of the research I did for this talk, I've realized that it can be a little bit longer than 5 years. But that's what I do. I tell them every year for the first 5 years. Juan, what do you do?
Yeah. Usually we go for 2 years.
2 years, yeah.
If the patient is fortunate and it's coming, sometimes we lose.
Juan, what do you do?
I tend to have the same problem Usama has. In patients that I can follow, RJ, I tend to follow them yearly for as long as I can. If they have been referred to me by an outside cardiologist, I tend to or try to stay in touch with the cardiologist and follow them with yearly echoes to make sure that nothing is coming back. But the truth is, we usually are able to follow them for an average of 3 years, after which they consider themselves to be in too good shape to come back to the hospital.
Yeah, I think that's reasonable. And Chiara, what do you do in Italy? What do you do with these people?
For myxoma, yearly echo for at least 5 years. For the strict follow-up for sarcomas is that due to the fact that in a short time they can change. The patient who I reported who had the relapse, local relapse after 18 months, had a normal MRI on normal CT scan, no signs of relapse on February 14th. I remember because it was February 14th, it's Valentine's Day, and he had signs of relapse on June 16th. So in 3 months, the local relapse was evident at CT scan.
Okay, well, that was a good first case. No more comments from the audience. Please feel free to ask any questions that you want to ask, because these are the experts and you can ask whatever you want. I tend to be a hog for the.
So I think that in the.
Go ahead.
So for the one a year is enough. Also because they don't go, if they have a relapse, they don't go so quickly as sarcomas do. If a sarcoma, you need a strict follow-up. For a myxoma or fibroblastima, it's not so urgent, because even in case of relapse, the goal is lower.
You do a follow-up echo or routine follow-up echoes for people who have fibroelastomas after, say, the first 6 months?
Yes, we do. We do yearly echo, but I've never seen
after operation. I mean, after operation.
After operation.
And have you picked up any new ones or no?
But I've not seen any relapse so far.
And what about in Egypt or Colombia? Do you guys do it for fibroelastoma as well?
Sorry, I didn't hear the question.
Oh, for fibroelastoma, do you have an echo follow-up period or anything like that for fibroelastoma?
Yeah. For all tumors, for cardiac tumors, we do. Yeah.
And one?
Fibroblastomas, I tend to follow for a couple of years only, RJ. No, not beyond that.
All right.